Today we are going to start our weekly scientific session of the EPSA, and today is a very special day. We have the pleasure to have Professor Dariusz, who is the head of Pediatric Surgery and Neurology Department and Wrocław University of Medicine in Poland. He's a well-known expert in many invasive surgery in pediatric, especially thoracoscopy. We enjoyed him so much in Egypt. He is a big friend for many centers of Egypt. A few years ago, he came here and visited us in Alexandria. He visited Tanta, Mansoura, Cairo, and we enjoyed his work so much. We are going to start with our EPSA president, Professor Sherif Shehata, who is going to talk to us about updates in the management of congenital diaphragmatic hernia. Please, Dr. Sherif, تفضل. Sherif.
Okay.
تفضل.
Good morning, good afternoon, good evening, based on whatever location you are. Today, actually, this is a very hot topic. We are doing in the EPSA educational weekly online meeting, but we have a grand event that happens this week. We have lost one of the huge contributors to the success of the MIS in the region, our late Professor Hisham Sakit. We hope that his soul rest in peace. He just died of COVID-19 last Friday. And since his main interest was the MIS, so we choose that this week will be on the MIS subject. And we all request that we are praying for him. And now we will go to our lecture regarding the diaphragmatic hernia update of the mice. Actually, this is the points we will discuss in the lecture. Just 3 weeks ago, the search on the PubMed shows that there is almost 14,000 topics and titles regarding the congenital diaphragmatic hernia. That means that till now we didn't have a good or solid hypothesis and theory behind this disease. And if we look to the background, that almost since Robert Gross in 1954 described almost 50% mortality, nowadays we still have 50% almost around mortality. And what is the natural history of this condition? If we look to the Caragni part, that we can see on the embryo of 9 millimeter, this is the start of the pleuroperitoneal membrane. And this is the heart, and this is the intestine and liver. If we go a little bit after, this is the at early 4th week of gestation, and this is the pleuroperitoneal fold on the right side, and this is the pleuroperitoneal fold on the left side. This is what is the term called the post-hepatic mesenchymal plate, which maybe have one of the rules in the delivery of the closure of the pleuroperitoneal membrane. And still it is hypothetical till now. If we look to the lung developments, we have to, in the foregut, we have the anterior lung buds that give the trachea and lung buds, then starting the branching morphogenesis to give the different bronchi, bronchioles, till the 6 smaller bronchioles, and will be the arterial supply of the lung following this airway. This is our first pole, sleep timer, you can put it. You have the audience or participants can choose what is the most important factor in lung hypoplasia that associate congenital diaphragmatic hernia. Is it the lung compression or environmental factors in utero or lung fluid circulation or fetal breathing movement? the result. How much is the first choice, second, third, and fourth? Actually, if we look to the pathogenesis of this anomaly, I don't know how much of you could say what is the most important of these factors. Actually, studying the different theories behind this anomaly, the start is a defect. As we can see here, this is most of the people say it is lung compression. And we can see what is exactly currently now. This is the old concept as done by Pogdalik in 1848, that the primary diaphragmatic defect is the primary anomaly, which is almost 70% of the participants choose it. So that, but later on, vessels came that mesenchyme is essential in the patient morphogenesis, and the airway established at 16 weeks of gestation in humans, and the blood vessels will follow that of the airway. And what is reported in different biopsies, that in the lung CDH, there is vascular abnormalities in the form of reduced total pulmonary vascular bed, and there is decreased number of vessels with medial hyperplasia of the pulmonary arteries and adventitial thickening, plus lung hypoplasia and surfactant deficiency with disturbed lung defense mechanisms. Actually, this is the situation in the normal pulmonary artery. This is the normal human. This is the almost normal thickness of the wall of the artery or arteriole, and this is the adventitia. In the diaphragmatic hernia patient, we have a small human, we have thickened muscle and thickened adventitia. And in a study for the lung cell culture, that some people say presume that hypoxia could be a factor. This is the lung human cell culture, and with hypoxia, there is increased the number of the alveoli as compared to the non-hypoxic. This was 20% oxygen and this 3%. So the in utero hypoxia is not existing. And what is the currently the hypothesis? This is the old one. That is it pulmonary hyperplasia producing diaphragmatic defect, and or diaphragmatic defect leads to pulmonary hypoplasia. But this is the recent theory of the double hit hypothesis, that there is a genetic and environmental factor beside, that there is lung fluid circulation inside with the respiratory fetal movement which is needed. This is push the mucus secreted within the pulmonary tree to push the things down. So any interruption of all of these factors will lead to the pulmonary hypoplasia. So the fetal breathing movement with the fetal lung circulation now has the upper hand. And simply because if there is, for example, laryngeal atresia, this patient with the laryngeal atresia will stop developing diaphragmatic hernia. So what is concept now that lung hypoplasia and abnormal pulmonary vascular development leads to the hypoplasia associating diaphragmatic hernia. This is part of the studies done that we can see. This is the adventitia in red, the thickened one in case of diaphragmatic hernia, and this is the normal lung, which is not the situation. And this is to exactly to show what is seen in the hypothesis. This is the alpha smooth muscle actin of the muscles of the arterioles around in a case of diaphragmatic hernia, and this is the condition in a normal lung. This much thickening means that there is all the time the high pressure zone in the pulmonary vasculature. And even if you look for some of the functional elements that you can find, the vascular endothelial growth factor staining, which is diminished in cases of diaphragmatic hernia with thickened arterioles as compared to normal. And again, for the nitric oxide, which is known as a dilating substance, this is a situation in a normal arteriole. It is increased expression, while in the diaphragmatic hernia, this is a faint expression. So it is not just a morphological one, plus it is a functional organ, because the lung is two units, the ventilatory one and the perfusion one, which are related to the arterioles. So we could conclude that maybe the vasoconstrictor endothelin has gained more power than the vasodilating nitric oxide. So that we can see that exactly this anomaly of 1 to 5,000, we have much neonatal problems, and all of us as a surgeon know that the surgical correction is not a challenge. But still the pulmonary hypoplasia with delayed maturation leading to hypercapnia, hypoxia, and surfactant deficiency, plus the reduced vascular bed and muscular hyperplasia leading to the pulmonary hypertension, making the high incidence of pulmonary compliance decrease with high mortality up to 40% till now. And this is what is called the hidden mortality in CDH. Actually, this is the picture of a stillbirth. This lung is almost 3 grams lung on the ipsilateral side of the hernia. Did you think this is good to withstand postnatal life? It is impossible to see that. So when the ventilation is done, with ventilation we can expand the airway and we can have improvement in the ventilation scan. But the perfusion scan in severe forms never to be changed. And this is why it carries a bad outcome with severe pulmonary hypertension. To manage such patients, this is the second part of my lecture. This is all we know, that this is a different type between the vertebral origin, the costal origin, and the sternal origin of the diaphragm. We have the posterolateral type, which is a common one, pogdalic, anteromedial Morgagni, and the central defect plus the membranous diaphragm. This is the types we all know anatomically, and the start of the diagnosis nowadays is antenatally, either by ultrasound or the antenatal MRI. This is the intestine in the MRI of a pregnant woman that we can see in the chest of the baby. After we diagnose the case and the patient is delivered, how we check? This should be done for each baby born, the birth checklist. Apgar score to be done at cyanosis and tachypnea, and any dysmorphic features in the newborn, front and back, like hemangiomas, polydactyls, and just putting a stethoscope, auscultation of the heart and chest. If we hear intestinal sounds, we have the diagnosis. Presence of anus without passing something in it, and passing in a gastric tube to exclude the esophageal atresia. Look for the testes and hernias, especially the inguinal, with looking through genitalia from the start to diagnose disorders of sexual differentiation. For CDH, on the plain X-ray, we can find the air-filled loops and the paucity of the abdominal gas with absent diaphragmatic copula, with mediastinal shift, and this should be put in mind that the diaphragm is the main muscle of respiration in the newborn and infants, and it is functional one, and it is continuously working. So it should have a little bit of doom to help in the mechanics of respiration. We rarely need the contrast to diagnose such condition, but should be put in mind and to differentiate from eventration and hiatal hernia. If we look to the cases with chromosomal abnormalities, like any anomalies should be put in mind. We have trisomy 13 with congenital aplasia cutis and diaphragmatic defects. This chromosomal abnormality is compatible with life, so we don't exhaust our infrastructure in the NICU or ventilation, or cases that we all know it is 100% mortality. And the management, we deliver these patients in a tertiary hospital with NICU, stabilize the patient, cardiopulmonary situation, put NG2 tube to minimize distension within the chest, and ventilate and assess the cardiac condition, and treat pulmonary hypertension. should be stabilization done first by the neonatologist, then we go for surgery. And this is our second pool. What is the percentage of neonates with congenital diaphragmatic hernia that mandate surgery? 50%, 70%, 100%, or 60%. Actually, I'm waiting the results of the pool, and I am going for some of the basic knowledge in diaphragmatic hernia because I know some of the participants are juniors. I think this is 70%, and this is the right answer getting by the participants, because we have to do it following stabilization. And when the patient came to you in the neonatal period, what is called the grades of severities, if you have the patient that survived, that present in the first 6 hours following birth, this patient usually have the highest or more severe pulmonary hypoplasia, and actually they are almost around survival of 40%. While the patients that could stay for 24 hours, this is grade 2, with survival of 70%, while the babies presented in the first 48 hours, we reach survival more than 80%. But any baby present after 2 days, that means he could withstand air room for 2 days. This is what is called delayed type with theoretical survival of 100%. That means this patient group is almost has no hypoplasia, but unfortunately, this represents only 10 to 20% of all diaphragmatic hernia presented. And if we look at the evidence with different management, high frequency, nitric oxide, ECMO surfactant, there is no evidence regarding improvement. The only available evidence is with gentle artificial ventilation in a proper way. And this may open that why there is some history of the fetal intervention. It started as open fetal surgery in 1981 till 2005 in San Francisco and stopped. Then came the open tracheal clipping, and currently is the tracheal plug. We will go one by one just to know. The fetus became a surgical patient. As we can find, this is an antenatal ultrasound with the patient with omphalocele and diaphragmatic hernia. And then this is the picture if we are going through the fetoscope, and this is the placenta up the cord and the feet of the baby. And this is the famous picture of Michael Harrison say with the baby in the open uterus saying thank you after doing the surgery for him. But these cases need a tocolytic drug. This is a picture with Michael Harrison. And tocolytic drugs has a lot of problems for the mother up to fatalities. And there was stoppage of this program after 51 cases in 2005. Then came the open tracheal plug. After discovering of a case of diaphragmatic hernia with laryngeal atresia, so the mucus of the airway tree push and fill the whole airway, pushing the diaphragmatic and intestine down. And this is the stabling of the edge of the uterus, and this is the circulation to reproduce the amnion after sterilization, and clipping of the trachea, and the patient is done this procedure around 26 weeks, but the survival rate of these cases was almost 33%. So it is also became stopped. And then came the experimental study on goats that we can occlude the trachea to fill it with mucus until it pushes from above the whole herniated viscus. And this is done through a percutaneous endoscope passed through the goat, and then we push this balloon in. And this is the picture from inside of the goat embryo. And this is the trachea rings start to appear, and then the catheter is pushed inside, and then we can leave it and delivery done later on. Actually, in Cincinnati, they start similar in human trial, the severe form with lung head ratio less than 25, and actually they choose for the fetal interventions the most severest form. So when we look to the figures of survival with low, that means they are almost borderline to be for death. While the moderate trial with much better lung head ratio, around 35%, with liver up, and the fetal procedure done around 30 weeks. And we can see the final sample. They, at 28 weeks, they do the fetal procedure. The blood is removed at 34 weeks, and then elective cesarean done at 35 weeks. And if we compare to the European study, they estimate the right lung cross-sectional area to the head circumference and measure at 25 weeks of gestation. And actually, when this ratio is below 0.6, we have 0 survival. It is more 1.35, 100%. And in between, different protocols have been utilized. For example, in CHOPS in Philadelphia, they took 1% with different survival, almost between 50 and 60%. And survival here means that the patient completed the pregnancy, not the patient is alive and repair is done. And this is in human being. With the help of the ultrasonic probe, we know where is the placenta, and a trocar of 10 millimeter is introduced under local anesthesia, and then another fiber optic in the channel with 1.2 fetoscope ended with a balloon that being dislodged to obliterate the trachea. And this is the track of the trocar number 10 in the wall of the uterus, 10 French cannula, and then we go inside by 1.2 fetoscope within this track, and this is the tracheal ring, and this is the small catheter carrying the balloon. It is by Nycomed, and this is latex balloon left inside until delivery. And after 10 years of this study, the delivery approached in 67%, that we lost 1/3 of the patients. And after delivery, they put in ventilation and the repair, and almost only 40% could have ventilation weakening. And this is the only permitted nowadays to be done in diaphragmatic hernia as fetal intervention. So maybe we don't know what is the future, but maybe the future, the baby say, no, I don't want anyone to interrupt me in the womb. And this is a baby, as we can see, with diaphragmatic hernia. This is the ventilation, the nitric oxide inhalation, the ECMO circuits, all these things to have good outcome. And this is a patient on ECMO. This is arterial venous type. This is arterial cannula in the carotid, and this is a venous one in the jugular, and this is the white lung following it. And this is the oxygenator, but there is a lot of morbidity and mortalities related to this ECMO procedures. There is edema, patient is hebronized, and a lot of bleeding complication. And in an evaluation of the results, we can find that the highest survival in meconium aspiration and the lowest survival in diaphragmatic hernia, 54% only. And how often you are using flaps or patches in repair, 1 to 10 or 1 to 5. This is the last part of my talk, the surgical management, or 1 to 20 or never. Thank you. Actually, the people giving that 1 to 10 may be a little bit lucky, but never that means he is lucky he didn't receive severe forms with wide defects. So if we go to surgery, it needs training. For example, if you have this patient with huge bilateral hernia, right and left, you have to put in mind, you need a good outcome. So you cannot do bilaterally in the same session because the abdominal compartment would be resulted. So you have to put in mind your plan of management to have a good outcome. And this is the modern classes of the size of the defect, which cannot be evaluated except intraoperatively. This is the A type, with all around there is a muscle. This is the B type, which is have small defects, but with small area with missing costal part. And this is the C, and the D is the completely absent hemidiaphragm. Actually, this is the open area. This is the patient preoperatively, and during repair, either you do it primary after reduction or using the patch. But this is a malrotation, 180, maybe with Mickels in the same patient. This is the left hypochondrium, and this is the cecum and appendix, which we could miss in some of the other techniques dealing with diaphragmatic hernia. So the surgical repair, either by direct suture, muscle flaps, or peritoneal fascia, or prosthetic patch, whatever the technique, we have to keep that to know diaphragm is continuously working, and the muscle should be kept in mind. And what is the best substitute? Sergio's composite mesh polytetrafluoroethylene, Marlex, or polyproline. I saw that the pool results is coming to the literature that almost 50% was, this is the best polytetrafluoroethylene, but polyproline shouldn't be used in direct relation to the intestine in the diaphragm. We have to put this in mind. And the follow-up, it is a long lifetime follow-up for this patient. It is not just simple. When you do surgery, this is the easiest part. For example, for the GERD, almost 1 every 4 cases of diaphragmatic hernia may need another procedure for the GERD. You have to continuous follow-up, and especially for ECMO survivors, which we can see that 40% need supplemental oxygen, and many of them, due to severe hypoplasia and wide defect, will need a patch repair. 80% may need diuretics and the bronchodilators. And so there is a polyclinic to follow up these patients, either from the complication of surgery or complication of treatment. And this is the European CDH study group. And I have to thank all the European collaborators for 15 years work. And since our outcome, to have a long and good outcome, not just killing babies for the challenge of the surgeons, this is the eras of the congenital diaphragmatic hernia care. Started by the immediate repair since time of Robert Gross, and then the ECMO started in 1984 with delayed repair, which is the standard since 1987, the gentle ventilation and dooming of the diaphragm. And we should look to the right heart. If there is right ventricular hypoplasia, this patient will be hardly to have good survival. And from 2007, starting the thoracoscopic repair. And at this time, we have this team of the invasive surgeons. And I have to quit. I am giving the talk to the leader of the team, my friend Dariusz Patkowski.
Thank you, Professor. Thank you very much for this very comprehensive presentation, Sherif. And now we move to our second speaker, was Professor Dariusz. Really, we can't wait to see his, minimally invasive approach for this major problem. Professor Dariusz, please. Dariusz?
Yeah, okay. I couldn't switch on my microphone right now. Yeah. Good evening to everybody. I'm very happy to see all my friends in Egypt, that I have beautiful memories from all my stay in Alexandria, in Tanta, in Cairo, in Mansoura. So everywhere I was always very, very happy to visit you. Thank you very much for your invitation. My pleasure to be with you. So, Sherif Shehata, congratulations on your lecture. It's really very difficult to speak after you. And I will give you a very practical lecture about the surgery, about endoscopic repair of CDH, and with my experience On the first slide, you can see my new hospital that I moved 2 months ago. So right now I am working in a big university hospital with almost 1,000 beds, with beautiful operating theaters. We have altogether 22 operating theaters right now. And for my pediatric surgery department, I have 3 theaters, including orthopedics also. So right now I'm very, very happy, but because of COVID pandemic, right now we limit our procedure to only 1 operating theater, but from in next week we will start to do more and more surgery. And I hope that this awful time will stop and we will be coming back to our customs that we had before. Of course, probably it would be very difficult, especially with traveling. So maybe we have to wait when we have a chance to meet again together. Right now we have a chance to meet through internet. So, okay, going with my lecture. Of course, there are very obvious advantages of endoscopic surgery, but especially for CDH repair, if you look into the literature, you can find many papers that present shorter duration of ventilatory support after endoscopic surgery, also decreased sedation in postoperative course, faster return to full enteral feeding, and also fewer severe postoperative complications. So it seems that it's very, very good to use endoscopic surgery. However, many papers reports increased recurrence risk and the need for reoperation. Of course, we don't have any procedure in surgery that is without any complication, but maybe, especially in these cases with CDH, maybe we should say that there is increased recurrence risk, but we have a lot of benefits, a lot of advantages. And if we discuss the risk factors for CDH recurrence, of course, the size of the defect. If you have a large defect in the diaphragm, it's obvious that the risk for recurrence is also very big. Patch repair. I think this is my personal view, that since we started to use patch repair, that comes, of course, with experience, because usually at the beginning we try to do the simplest operation as it is possible. But when we started with patch repair, the number of recurrence is really coming down. So maybe size of the defect, the tension in the suture, these are the risk for recurrence for CDH. And of course, endoscopic technique, disease severity and ECMO treatment, and probably the most important thing, the most important factor is the skill of surgeon. So his experience with endoscopic surgical suturing probably and learning curve are the most important factors when we think about the recurrence. This is the experience of my center. Probably it's not so many cases like in Egypt. We have operated 46 cases at my department. And if you can look into our experience, there were only 3 conversions, 2 at the beginning and the last one in 2015. I will show you this last one later because it's very, very interesting. And as you can see, there are not too much conversions. And there are 6 cases with patch repair that we were using at the last series, and especially with our growing experience. And if you think of course, we have two options if you think about endoscopic surgery: thoracoscopy approach or laparoscopy. So which is better? Of course, it depends on the type of the defect, size of the defect. And if you, this is my very simple indication for thoracoscopy and laparoscopy. So in majority of cases, I think that thoracoscopy is the best option, because in the thorax, we have a natural big space for doing endoscopic surgery. So all cases with posterolateral hernia, especially in newborns and infants in children, and also right CDH is especially very good indication for thoracoscopy, as the liver sometimes prevents to have a good access to the diaphragm. And for laparoscopy, of course, the obvious indication is retrosternal hernia. And the other cases, like complicated cases or recurrent diaphragmatic hernia, is for discussion. So there is no special equipment for endoscopic procedure with CDH. I am always using 5mm telescope, and sometimes right now we have a very good equipment with 3D visualization, but 3D requires 10mm scopes. So for newborns, it's a little bit too big. And 5mm telescope give you really a beautiful access. I'm always using a 25-30 degree scope. This is my saying that such a scope you can use always, and the straight scope, 0 degree, you can only use from time to time. So I always prefer only this kind of scope, so we even don't have any 0 degree scope at my department. So optic port 5mm, if you are working with a newborn, 3mm instruments are very good, not very long. 20-25 centimeter, it's quite enough. And of course, if you have older babies, you can use 5mm instruments also. And the special for discussion is insufflation pressure, because especially for CDH patients, CO2 is very harmful. And some people say, oh no, endoscopic surgery should be contraindicated for newborns with CDH because of the risk of CO2 insufflation. But when you look for the thoracoscopy, of course, at the beginning of the procedure, you have to use about 5 to 6mm mercury pressure. But when you put the bowel down, then you can even switch off your insufflator. You don't need any pressure. So usually when we put the bowel down and we just start with diaphragm repair, we lower the pressure to 1 or 2mm. And this is just only to have some exchange of gases in the thorax to prevent foggy of the scope. But if you stop the insufflator, you can still work, because thorax is a natural space, big natural space for doing a surgery. So I think, in my opinion, CO2 is not any using a CO2 for CDH repair is not a contraindication. There is a paper published a few years ago from Great Ormond Street, and they stated that using a CO2 for patients, for newborns with CDH, is very harmful because it decreases the oxygen supply to the brain. But when you look to the data in this paper, they were using pressure up to 15mm of mercury. So, you know, it's not a good paper, and we shouldn't discuss this paper because the data for this paper were not chosen rightly. So patient position, usually this is a lateral position if we are doing a thoracoscopy. So you are working across the table, or you can put the baby at the top of the table. So it just depends on your custom. If you are working across the table like here, the only problem with this position is that if you have to convert, maybe sometimes it is difficult. So probably it's better to put the baby like this, alongside the operating table, but it's just for your option. Very important is the position of instruments. So the first instruments, I always put it in open way. We are not using Veress needle. So the first is in the mid-axillary line, as high as it is possible. Both two other instruments are placed in the posterior and anterior axillary line, or even more down, just to, if you put it down, you have a good access to the chest wall. In other way, you cannot bend your instrument. So that's the rear problem. So these instruments, working instruments, should be very apart from each other. So just put it down a little bit, and in this way you can work and you can suture the diaphragm to the chest wall. So usually at the beginning you have the picture like this. You must be very, very careful. Of course, this is a little bit speedy video. You must be very careful just not to injure the bowels. And the problem is usually the spleen that is inside the chest. So you must be very careful to move the spleen. You have to use the side of the instruments. And this is just after the defect was repaired. For the suturing, I'm using non-absorbable suture, the 2O braided suture, or a kind of Ticron or Etibond, or something that I call no-name suture coming from China. This is the other case. In this case, you cannot see the spleen. This is just a large bowel here. So it's much easier to put the bowel down, and you can see the defect. It's easy to start suturing from the medial part, but then you have some problems with suturing this part that is close to the chest wall that I will show you on the next picture. I like this film very much. This is the way you can measure the size of the defect using the line. And this is the film that was recorded in Tanta during my stay and when we had a meeting. And this is a beautiful video that I like very much, with a very good quality mesh. And you can see that in this case, the defect was really very big one. So you can see that in this case, I was using a continuous suture, suturing the mesh to the defect. And then you can see that there is almost no diaphragm to the chest wall. So for this suturing, I am using the pierce technique that I am using for inguinal hernia repair. And this is a very useful, because in this way you can suture the mesh directly to the chest wall. And on the skin, there is just only the puncture side without no scar, using this technique. And this is also another one, continuous suture to the diaphragm. As you can see, there is almost no tension when you use a mesh. And I think this is a very good example how to prevent the recurrence. Of course, the basis for this operation is a very good suturing technique. So you must be very, very experienced with suturing. And if this is not a problem for you, you can do a beautiful operation. And you can see this is the pierce technique for suturing the mesh to the chest wall. So the knot of the suture is under the skin, like in this case, you can see this is just put under the skin and then cut off. So there is almost no scar on the skin. You can put as many sutures as you want. And step by step, you can put it around the rib or just use muscles inside the suture. So this is just at the end of operation. This is another one case. It's very unusual in Poland, in Europe, to have a CDH with a sac. I know that it is very, very often in Egypt. And in this case, usually you have a very good diaphragm, so it's easy to repair. To my experience, it's not many cases, but I never cut off the sac. I just put it inside the suture, just under the diaphragm. And in this case, you can see that the diaphragm is very thick. There is no tension, and it's really easy to repair. Usually I start suturing from the medial aspect, then going to lateral one. That's very interesting case. This is a 5 months old baby. She was accidentally diagnosed to have a CDH on right side. And on the ultrasound, it was liver inside the chest. So this is a good example that you can always start with the endoscopic procedure, and then after checking what's inside, you can decide whether to convert or whether to change your technique. But look for this case because it's very interesting. You can see bowels, and under the bowels you will see the whole liver that is inside the pleura, inside the thorax. So we are thinking what to do. You can see the kidney here. This is a defect. So I was just looking around the liver, what to do with it. You can see the cava, the heart here. And suddenly, when I grasp the edge of the diaphragm, the liver slipped down into the abdomen. You will see in the moment. So it was easy later to repair. You can see, and the defect was not so big one, so it was easy to repair. So you can see that it was a good decision to make endoscopy for this, to start with an endoscopy for this baby. Another one case, 6 months old baby admitted to our hospital at night as an emergency case, vomiting with the signs of bowel obstruction. And on the X-ray, you can see very dilated bowels, and the baby was really in a very severe condition. So we had a discussion what to do with this baby, how to approach this baby, whether to start with endoscopy or whether to open the abdomen or the chest, or both the chest and the abdomen. And after a big discussion, we decided just to check through the umbilicus what's going on, and you will see in the moment, because it's really very interesting case. The baby is in the lateral position. The scope is in the umbilicus. There are 2 working ports. And as you can see, it was a surprise for us that bowel condition was so good. We were afraid that there is some necrosis. But as you can see, there is no problems with the bowel. You can see the liver here. And at the moment, you will see the defect. It was really a very small 2 centimeter or 3 centimeter small opening in the diaphragm that was really very easy to repair. just with 2 or 3 stitches, and that was all, you know. So as you can see, sometimes it's really worth to check, to use an endoscopy for diagnostic purpose, and then to decide what to do. And there is another one case. This is a retrosternal case of CDH. You can see the defect on the left side. So for such a case, we use a pierce technique. So even it is possible to repair it without any instruments inside. But for this case, we are using a pierce technique and also some coagulation to burn the surface of the defect to have a good adhesions. As what's interesting, there is a publication just recently, as you can see, coming from Turkey. There was Dr. Ergun who was visiting my department, and he was watching this procedure. Then he repaired some cases in his department in Ankara, and there is a publication about this technique coming from Turkey. And in Turkey, the pierce technique for inguinal hernia repair is very, very popular. They are using this technique also, and you can see this is the case that was operated at my department. So you can see that step by step, using pierce technique, you can repair it, you can suture the defect. As you can see, I was not cutting off the sac of the defect. And you will see, you can see some burning here by coagulation. And this is the final results of the procedure. The defect was completely restored, and the case was doing very well. And of course, there are some recurrence that, as I mentioned, that this is the example for recurrence. There are 2 cases that I was using laparoscopic approach. And as you can see, there is a lot of adhesions. The defect in this case was not so big, so it was possible to repair it just with suturing. But in this case, we had a lot of problems because there was a lot of adhesions. So we had to open the case. Maybe today, with our experience, we could manage it by endoscopy, but it was really very difficult to cut off these all adhesions and to repair the defects. So we decided to convert this case. And there is a very interesting case that was diagnosed to have a recurrence, or maybe it was an eventration of the diaphragm. So we performed a thoracoscopy, and we found that's interesting. Look for it. This is a liver, a part of the liver, herniated into the thorax through the very small defect in the diaphragm. The defect was about 1 centimeter in diameter. And through this defect between stitches, you can see the line of the stitches here, the old one. And through this small defect, the liver herniated, and it was growing into the thorax. So as you can see, it was about 3 centimeters in diameter. So I ligated it, cut it off. You can see the line, the old stitches here. And after cutting it off, you can see step by step. The defect was repaired with single sutures. You can see the small rounded defect. So through this defect, the liver herniated into the chest and was growing inside the chest. That's interesting, really interesting case. So just to summarize in conclusions, what I can say that endoscopic surgery for CDH repair is really a right option. So this is our first choice for every case Cannot say. Maybe if there was any for cases for reoperation, maybe sometimes you can think about open procedure, but usually you should start with endoscopy. And thoracoscopy for me is a preferred approach, especially on the right side. And this is sometimes it's just only for a diagnostic purpose, but in majority of cases you can do it with endoscopic technique. And even for difficult cases, I think that endoscopy is the first option. And for all these procedures, perfect suturing technique plays important role in prevention of recurrence. Thank you very much for your attention.
Thank you, Professor Dariusz, for this very interesting presentation. We have all learned from you how to do this procedure, and you take your time and be patient and work very slow and respect every stage. Thank you very much. I'm sure now we have many questions, but I think Professor Sherif has a small, talk about minimally invasive surgery in low resources countries. Is that right, Sherif?
Yes, yes, Dr. Ahmed. Yes,
okay.
Professor.
Go ahead, and then after that we'll get the questions.
Okay. Once again, it's very hard to speak about Dariusz Patkowski, our friend, but since we are in the era of endoscopic surgery, this is the CDH International Group for Supporters. And again, this is our late Professor Hisham Saket, which his main interest was in the propagation of minimal invasive surgery. And this is the first thoracoscopic animal neonatal course done 2 years ago in a rabbit model that we have to learn CDH exactly, one of the topics that we discuss today. And this is Dariusz with us in Tanta during the minimal neonatal course. And actually in Seattle 2 years ago, Mark Wolken put for CDH, is it minimal or maximal to use the minimal invasive surgery? When we need a prosthetic mesh or abdominal exploration or the uncertainty of intraoperative complication and a long non-progression, is it a limitation of the procedure or indication? Dariusz already spoke about some part, and this is one of our best indication. Our last poll for MIS is it stable neonate, small to moderate defect like A and B, surgeon experience or Morgagni type. And I think after Dariusz' lecture, all of you could answer this. Definitely the stable neonates and surgeon experience is the most important, and all of these factors can play a role. And the guidelines we applied in Tanta, that when the patient is delivered, we have to stabilize that there is the difference between pre-ductal and post-ductal oxygen saturation less than 15. And it is simply can be using a pulse oximeter on the upper limb and lower limb. And this indicates that there is minimal shunting. And with NGT tube and after assessment of the heart condition with treatment of the hypertension in the pulmonary area, so the patient is stabilized, you go for surgery, and whatever your technique and experience you can go on, but you keep in mind, put a patch to prevent recurrence. There is no need for tension, diaphragm is working, and there is lifelong follow-up. And in our experience, we started that this is our exclusion criteria. If there is much instability with difference more than 15, big defect, or early antenatal diagnosis that can be diagnosed before 30 weeks of gestation, with thoracic stomach and need for prosthetic mesh or bad general condition. I think maybe this is a form of bias for not to be in thoracoscopic group, but this is the only way that you can build up your experience to have good outcome, and then you can go for more difficult cases. One of the important things that we can use the oxygenation index, which we can measure the mean airway pressure in the fractionated inspired oxygen over the partial pressure in the arterial blood with cutoff of 5. This is a good indication to go for thoracoscopy. In our low resources, we have much experience in the NICUs or very severe types, so we try to keep it minimal. In the last 7 years in Tanta, we have almost the whole group of pediatric surgery, 117 cases of CDH, and only 55 cases have been subjected to the minimal invasive surgery. We have only 37 neonates have been operated thoracoscopically. 2 cases never operated. There was no stabilization. And we have 7 conversions, 2 due to intraoperative splenic injury and 2 due to the need of mesh. We could win 30%, 30 cases among these 37, and we have 6 mortalities, almost 18%. And here we can show one of our cases, maybe as mentioned, that this is a 3 days old boy. This is the pre-operative X-ray. This is as described. There is a sac, which is, we can see the intestine behind the sac, which is a rare association to find the sac. And after reduction, usually we employ exactly what is employed by Dariusz. And when we push, we don't try to open the sac, but we could explore. And at the end, after we look from the medial side, this is not big defect. And we can see here, this is the extralubar sequestration with the mushroom appearance. So we can deal with at the same time from the chest side. Sometimes if you are doing such cases abdominally, you can miss this one because the attachment in the medial border. And after securing the pedicle of the extralubar sequestration, we start to suturing the defect. And suturing, as mentioned by Dark, that you have to have the experience to work in this small space, and it is easier from the thoracic side than the abdominal side. And after removing the extralubar, we don't need to cauterize the edge of the sac. We don't try to open the sac even. It is help you in reduction, and we take the sutures. Usually you have good muscle, and we can make the temple square tying that we can approximate the defect and close it. As we can see, we use non-absorbable braided, ethibond or ticron, and sometimes we can use proline even in such cases to close it for the complete closure of the defect. And this is self-sliding. We start from the medial side as we prefer many times, but we make suspension from the lateral edge to help us. And later on, we can use another stitch with proline, and the defect is closed easily. And so still, in conclusion, till we have a good outcome to be warranted, we don't think that in our situation or where there is no good infrastructure, it is not only as a surgeon, but as a NICU, as a whole setup, if you need prosthetic mesh, if the patient does not have very severe form of hypoplasia, you have to put in mind the level of experience done. And if there is no progression, still this is a limitation for CDH repair from our experience. And thank you for attention.
Thank you, Professor Sherif, for this very nice presentation. Before opening the floor for discussion, I just want to have some comments really. Here in Alexandria, after the visit of Professor Dariusz, we've been stimulated for doing thoracoscopic repair of CDH. And you have MD thesis, and it was successfully discussed 1 month ago. And you know, this was our experience with CDH. And now I can tell you that the neonatologists, when we have case of CDH, they call us by phone and say, please, can you do it thoracoscopy without opening the chest, because we found the results are much better. So this is one encouraging thing. The other thing I want to comment is that sometimes we do the stitches extracorporeal by not pusher. And really you find it going very well and fast. And I don't know what experience Dariusz or Sherif about this extracorporeal knotting. using the node pusher. My last comment regarding the intrathoracic stomach. In our practice, I know this is mentioned in the literature, but we didn't find the intrathoracic stomach change the prognosis. Sometimes you have total, the stomach, all the stomach in the chest, and the survival is okay. And sometimes you find it in the abdomen, and its survival is bad. So I think intrathoracic stomach alone per se is not. It should be taken in context with other prognostic factors. Thank you very much. Now we are going to open the floor for discussion. Dr.
Yes, Dr. Ahmed Khairi, this is Adam Saeed. We have been taking the questions online in the chat room during the speech from Professors Dariusz and Professor Shehata. So the questions are ready. There's a question for Professor Shehata from the floor. One is asking the diagnostic, if it's true that the results that you have shared with us will differ if antenatal diagnosis was done or not, which means that you have shared some results or predicted results of CDH management. Does it differ if you're going to do it antenatally or not? If you're going to know prenatally that you've got a CDH?
Hello, thank you for this question, actually, Adam. But actually, the meaning of antenatal diagnosis, that when you are diagnosed the case as early as you can, if you do antenatal diagnosis at 28th or 30 weeks of gestation and there is CDH, that means it is of severe degree of lung hypoplasia, rather than if you are only noticed in the 34th weeks of gestation. And the start of the intervention antenatally actually didn't help, because they choose the most severe cases to be subjected to this type of management. But if it is still the best outcome that the patient is delivered, and later on there is ventilation even with exit procedure, and put it in gentle ventilation and do your repair. Because when you are severe form, from long-standing compression from the early or mid-gestation, at the end, it will be ended by usually almost around 30 to 40% only survival. But in our area, in the world, many of these cases, we didn't have to see it. They are died before they reach to us.
Okay, thank you, Professor Sherif, for making this evident, that antenatal prognosis or prenatal prognosis only makes you just be prepared more for the baby and does not differ in the outcome. That's right?
Yes.
Okay. So we have a question from the floor also by, what is the meaning of gentle ventilation? What does it mean?
Actually, this is the from the start, there wasn't the ventilation in the neonates. It is usually they prefer the low pressure with medium volume ventilation, which should be in the modern neonatal ventilators. The old ones, or the pressure only ventilators that been used in adults, will not help, because it could induce for these fragile lungs a form of pneumothorax. And the experience of the NICU and neonatologist will be reflected on the outcome for you as a surgeon. It is a multidisciplinary approach. As much as they have experience, they make a very low setting and try to keep the setting, like exactly when they are giving the high frequency ventilation. It is they are giving a very minimal for a longer duration with successive, more rapid numbers of pushing of the oxygenation to ensure that there is no sudden inflation. And this is the era of the gentle ventilation by the neonatologist, not by the surgeon.
Okay, we have another question for Professor Shehata. There is a case of massive eventration that was diagnosed antenatally, and it was ventilated from birth with nitric oxide. Should it be managed differently from diaphragmatic hernia with TAC? And what is the timing of tracheostomy when home ventilation is likely?
Timing of what, please?
what is timing of tracheostomy. He predicts that there will be home ventilation, and he thinks that he could need tracheostomy. So when do you do that?
Actually, we have to put in mind that the antenatal diagnosis of such condition and the patient with persistent pulmonary hypertension that necessitate nitric oxide therapy, usually there is a moderate form of severe lung hypoplasia and should be taking a lot of things with it, not just home oxygenation or ventilation. And the best time that when the setting is low for your patient and you can wean him off, maybe at the end of the neonatal time, around in the 3rd or 4th week of life, if the patient is doing well with tracheostomy, you can put it at that time. With as early as you put a tracheostomy, there will be a continuous problem, and maybe you end with a permanent tracheostomy.
Okay, thank you. There's a question from my friend to my friend, Professor Dariusz. What do you think of MIS in the era of COVID-19? Are you willing to perform MIS in the era of COVID-19 or not? And what are the precautions that you would take during this surgery?
At my department, we didn't stop MIEs, so we are still doing laparoscopy. Of course, we are trying to avoid any leakage of CO2 from the abdomen, so usually we put a special suction to evacuate any air coming from the abdomen. But even when you look to literature, and also there was a lot of discussion on the WhatsApp and other social media, there is no clear contraindication to use endoscopy in the COVID pandemic time. If you have a patient with a COVID infection, probably this is the case to discuss whether the open surgery would be better for such a patient. But maybe this is the only contraindication that I could imagine for such a patient. But usually, you know, you have to always think about benefits and negative effects. So there's a balance between two, so you have to choose. But for me, every case is superior if you are doing endoscopic surgery.
Okay, so you are fond of still using MIS in the era of COVID-19.
Yeah, I use it.
You use a smoke evacuation system with ultrafiltration?
We are evacuated any smoke with a special suction device that we have in our insufflator. We have such an option at our insufflator that you can evacuate any smoke from the abdomen.
Does your operative room have a negative pressure system?
Yes, we have a special pressure in this new room. We have a special ventilation. Yeah.
So if you don't have an operative room with a negative pressure system, and you don't have a smoke evacuation system with a filter, with an ultrafiltration device, would you still stand for doing laparoscopy and thoracoscopy in the era of COVID-19?
Yeah, there is no study that presents that there is a huge risk for with the air coming from the abdomen or from the thorax. Of course, we know that the main source for the infection is the air from the airways. So if this is not any clear infection, I don't think that there is a huge risk.
Yes, okay. So we'll go to another question for Professor Dariusz. In centers with bad management ventilation supply, what would you suggest early surgery, or would you delay it?
We always delay the surgery as late as it's possible. So if the baby is unstable, so I don't think that open surgery will be better than MIS. So if the baby is unstable, we don't take any surgery. you are just waiting for stabilization as long as it is possible.
Okay.
Because we don't think that any kind of surgery is beneficial for such a patient. Yeah.
Thank you, Dariusz. So we have another question. In cases with bilateral congenital CDH, what is your approach? Actually, a very rare case, but what's going to be your approach?
Okay, that's a very interesting question. We just recently published an article about a case with bilateral CDH. And what was very interesting that it was not clear diagnosis at the beginning. So at the beginning, it was the right-sided CDH that was repaired by thoracoscopy. And after 3 or 5 days, something like that, on X-ray, we found that there is also on the left side. And what is very interesting, that the X-ray taken after the first procedure didn't reveal any pneumothorax on the left side. But it was a clear defect on both sides. And in this case, both sides were repaired by endoscopic approach. And first one was on the 2nd or 3rd day of life, and 4 or 5 days later was on the second side.
Thank you. So if you have a bilateral case, you will do it one at a time.
Yeah, I think that because, you know, there is no necessary to repair both sides, because, you know, the surgery is nothing special for CDH.
Okay.
So if the baby is on ventilator, it doesn't matter whether there is a defect in the diaphragm or not, whether it is repaired or not. You know, if the baby is on ventilator, it is breathing with ventilator support. So you have a time to repair one side. Of course, if it is possible, the baby is doing well during the procedure and you can do both sides, you can do it. But usually, you know, we try not to have, we think that 2 hours for endoscopic surgery is just enough for the patient. So if the procedure is becoming longer, there is no time to do another one side. Yeah.
Excuse me, Adam, may I have a comment, please?
Yes, please.
Okay. Okay, especially for these cases of bilateral, I think it is better usually to do one at a time for the abdominal room. Don't compress the IVC. And I think also that it is better to start with the right side. You put the lever down, it is heavy, rather than to start with the left side. What is your opinion, Doc? Better to start with the right, with the lever down first.
Okay, this is my opinion, but I cannot imagine to do a laparoscopy in a newborn with CDH, because usually in such a case, abdomen is so small that you cannot do endoscopic surgery. So this is my preferred technique, that I always start with the thoracoscopy, because there is a space. So of course I agree, just do one side at one operation, but start with the thorax, not from the abdomen. I cannot imagine that you can do it from the abdomen, but I know that there are reports that people are doing it from the abdomen, but I think it would be extremely difficult. And especially if you start from the laparoscopy, you have to use a big pressure. But when you are doing it through the thorax, almost you can stop the insufflation. Yeah.
But you start with the right side.
Yeah, that's a good idea. That's a good idea.
Adham, may I have a comment, Adham, please?
Yes, please, Dr. Ahmed.
Yeah, I have a comment really regarding bilateral CDH. It does not mean that both sides have bowel loops inside. So I think the point of afraid from concern regarding abdominal compartment, it's not valid, because even if the case Dariusz spoken about now, the left side didn't show unless after he reduced the contents from the right side, and then they started to go through the left side. So I don't think there is a point. I think the main point here is the positioning of the baby and the timing of the lengthy operation. I think this is the main concern. I'm not sure the compartment syndrome have a place here. I'm not. This is my opinion.
Okay, dear sir. We have lots of questions for Professor Dariusz. We will come to the next question. It says, what's the limit to stop the procedure as regards hypercarbia?
When you are doing endoscopic surgery for newborns, usually you have a rise in CO2. So if the procedure is more than 1 hour, usually you have even 70 to 80 CO2 rise. But usually after the procedure, it goes down very quickly. So it's not a real problem. The main problem is to keep a good saturation. So usually during the procedure, the saturation is about 90%. But if you can see that the baby is not doing well, you can always stop the procedure or you can convert or something like that. But especially for CDH, we cannot see any change in CO2 because we are almost not using CO2. So the absorption of the CO2 for CDH is really very small. So it's not harmful. This high rise in CO2 we can observe for patients with esophageal atresia repair, for instance. Yeah? But for CDH, because we are always not using CO2, because even we switch off the insufflator, the rise is very small or even not.
Okay. Professor Dariusz, what do you feel about some surgeons, they cauterize the edges of the CDH respect? Would you like to do that?
I think I'm always thinking about it. Sometimes I am doing it, and I think it's a good option because it makes, if you cauterize, if you burn, you will make an adhesion. If you make an adhesion, probably it's something that will add to your operation. And as you can see with my last video, there was just herniation between sutures. So probably if it was any cauterization or burning of the tissue in this area, so probably there would be an adhesions that would prevent any herniations through this defect. So I think it's a good option.
Okay, thank you. Other questions also on the technique. The role of Teflon pledgets in the repair. Do you use any Teflon pledgets or other pledgets in the repair?
I know that people are using it, but if you don't have a big tension, you don't have to use it. And if you have a tension, you should use a mesh. So I am not using any pledgets.
Okay, next question, Professor Dariusz. Do you take sutures at different levels, or the line of sutures is linear? That is, do you go to the right, then to the left to just distribute the tension?
You know, the biggest tension is just near the chest wall, you know. So usually we start from the side, from the medial aspect, because the tension is very small and you can step by step decrease the tension. If you start from the lateral aspect, the distance between edges is very big. You have to use a very big tension without any other suture support. So usually it's better to start from the side that you have less tension and step by step approach to this big size defect. Yeah.
Do you find any difference in results between application of interrupted sutures versus continuous suturing in your results, or you don't use continuous suture?
Oh, you know, the continuous suture I am using only for pyeloplasty. For other things, I am using interrupted suture, and especially for the diaphragm, I think it's very important because, you know, if you broke the suture, if you have a continuous suture, it will goes completely alongside the defect. So if you are using interrupted suture, it's much better.
Okay.
Excuse me, Adam, may I have a small comment for this area? Actually, the sutures are in one level, not in different levels. But you are looking with a 30 degrees telescope to the dome of the diaphragm from above. So it appears that the medial edge sometimes is in another level than the lateral one, because it is like you are looking for the dome from above.
Yes.
But usually it is in one level. This is just to explain it. It is not in different levels. Okay.
We do that all in one level, but the question was, do you do it on different levels? So what we do,
only one layer. Only one layer. One layer.
So we have a comment from Professor Marcella Bailey. Professor Marcella, we will unmute you if you want to share with the comment. Professor Marcella, could you hear us?
المايك بتاعها مش activated ادهم يعني لو تقول الكويشن بتاعها.
No, she said that she uses a continuous suture on top of the interrupted suture in her case. So what do you think of that, Professor C?
Actually, this is only valid if you have a good muscle that you can overlap it. I don't think what is the opinion of Dark, but if you have just, you are closing it in one layer, it is very hard to put another layer over it, except if you are putting another small patch or part of the muscle or pleural flap over it. But for the muscle, which is very, not in much cases that you find good muscle to make 2 layers repairs. What's your opinion, Dark?
I think that continuous suture is very good if you have a mesh. If you have a mesh, because there is almost no tension, it's very good to suture it. But if you have any tension, it's better to use single sutures. Yeah. So as I presented in my videos, you know, and especially you can use a continuous suture, but not on a very long way. So I mean, it should be interrupted after 5 or 6 loops. This is just my opinion, but you know, my experience in CDH is not so great. You know, probably in Egypt you have much more experience, especially about number of cases. You know,
Darius, you're always so modest. Sir, there's a comment saying that the mesh does not grow as the child grows. So do you think that if you're going to put a mesh, do you need any further repair or intervention further in the future?
That's a very interesting thing, you know, but this is my opinion, that it's not a matter that the mesh is not growing. The diaphragm is growing. So, you know, the mesh should stay the same size as it was, but the rest of diaphragm will grow up, you know. So that's a natural way of developing a diaphragm, because in a normal baby, in a healthy baby, the diaphragm is also growing with the size of the baby, you know. So this is the same for the repaired diaphragm. So usually the defect is becoming smaller and smaller to the rest of the diaphragm. Yeah, so it's not a matter. I don't think that it is necessary to repair it.
Okay, there's another question. Would you resect the sac if you have a hernia with sac? Would you resect the sac?
As I understand, you ask about the sac, yeah?
Yeah, the sac. If you have the flat.
I don't resect it. I don't resect it. I just leave it intact.
Does it affect the recurrence rate or?
Sorry, cannot understand.
Does it affect the recurrence?
I don't have a case about recurrence because of the sac, you know.
Okay. There's another question. If you don't have the
Hello.
Hello.
Yes.
Adam?
Yes.
Adam?
Yes.
Go ahead,
Repeat
Adam.
your question, please.
Repeat the question.
Repeat, please. Repeat, please.
Okay. If there is no diaphragm on the costal leaflet, there is no, the costal leaflet is deficient, what would you like to do?
This is what I presented you, just to use a mesh that I suture to the chest wall with the pierce technique, the single sutures placed through the chest wall. So this is the way we manage it. And usually if you have a huge defect, there is no rim at the chest wall. Sometimes you can find something under the peritoneum, but it's not very often. And even if you find some rim of the diaphragm, it's very delicate and it's really very difficult to suture it because it ruptured, it break. So usually you have to use a patch repair, and you suture the patch to the chest wall with single sutures with the pierce technique.
Okay. Small comments, please, Adam, because not all of us are Dariusz. If you have such very big defect with very few fibers of the diaphragm, it is not to be done endoscopically. To be done open may be better for the whole outcome. Until you have the experience of Dariusz. This is
yeah, this is a wise comment. Professor Dariusz, would you prefer using bronchial blockers to help collapse the lungs, or double lumen tube, that's one lung ventilation or something?
I am doing a lot of thoracoscopic surgery, and maybe just a few cases that I was using any blockage to the bronchus. It's not necessary. Usually you can control it with the pressure, so it's not necessary.
Okay. So there is a common question. They say that abdominal exploration for other anomalies is not feasible when you're doing thoracoscopic repair. What do you think about it?
Yes, it's right. And majority of cases with CDH has some kind of malrotation, but usually this kind of malrotation very seldom to the statistic requires any surgery. So I don't think that this is any indication, if you find any kind of malrotation, that you should do it from the abdomen. You can repair it from the chest, and later, if there is any problem, you can do it for laparoscopy, or you can open the abdomen. But it's not necessary to repair it at the same procedure. Usually you create some adhesions so that prevent any torsion later. But of course, if you have any problems with malrotation, then you have to repair it. But you can do it always later, especially that you cannot check it during the procedure. There is usually no obvious indication for malrotation repair.
Okay.
Excuse me, Adam, just
comment. Yes, please.
If we are looking to the literature, the malrotation associated diaphragmatic hernia is ranging between 15 to 25%, but the number that need further intervention is less than 2%. That means obstructing malrotation. So we don't hinder the benefits of 100 cases just for 2 cases that maybe later on you can deal with. This is by the level of evidence and literature reviews.
Okay, you have made that point very clear. There is a question, do you think that the recurrence of CDH is related to the fast growth rate of the diaphragm in infants?
Excuse me, once again, the recurrence is related?
Yeah. Is it related to the fast growth of the diaphragm in infants?
To my opinion, any recurrence in CDH is mainly related to the technical problems, to the surgeon.
Okay.
I am totally agree with this point, because in the small children, the muscle can come easy to each other and under tension, and afterwards you will get ischemic. So you have to leave some part to be floppy or dooming, that you be sure that you have any degree of tension. Otherwise, as Dariusz said, it is surgeon problem.
Okay, question for you, Professor Sherif. Question for you. Yes. What's the timing of operation for recurrent CDH? When would you prefer to do a recurrent case of CDH?
Actually, the recurrence of the CDH, once you are diagnosing it, because usually it is just a small or one suture slipped on. You can have it complicated by, for example, strangulation of part of the intestine. So once you diagnose, it is better you go in.
What do you say of that, Professor Dariusz?
The same opinion. If the baby is even if the baby is asymptomatic, and if you have any bowel that are herniated into the chest, you have to repair it because the risk of strangulation is really very big.
Professor Sherif, do you think that serial echocardiography during stabilization of the baby is essential in predicting the time of surgery? Would you rely on it?
Echocardiography?
Yes.
Echocardiography.
Yes.
The only two things that we rely upon echocardiography is the size of the right and left ventricle. If you have ventricular hypoplasia in a certain degree, please don't touch this patient. This heart will not cope with. And the second point estimated by the echo or echo duplex is the degree of shunting for the pulmonary hypertension, right to left shunt.
So
if
you would rely on
means your patient is not stabilized.
So you would rely on the echo.
Yeah, it's very important. It's for just checking the baby. It's a good indication whether the baby is improving or not.
So this question, the coming question, is very important. Would you operate on a CDH patient who is severe preterm, like less than 30 weeks? And if not, when would you operate on him?
You know, this is my opinion, that if the baby is on ventilator, the surgery is nothing special. It will not help this baby. Until the baby is on ventilator and is stabilizing, so just defer the surgery as late as it is possible. So if you have really a very preterm baby, so you can wait 1, even 2 weeks without any surgery. It's not necessary to operate such a baby because the surgery will not help very much to these babies. This is my opinion. This is my feeling, you know.
What do you think, Professor Sherif?
I think this is the standard, because if the patient is not stabilized, it will never stabilize. Surgery will not add. For that, one of my questions, how much? Actually, if you are dealing with all babies, 30%, you will not touch them. They will add it to your just mortality. If it is not stabilized by ventilation and pulmonary hypertension treatment, surgery will not help. Will not add stabilization.
Next question is a bit difficult. So if you diagnose a baby with CDH or an fetus with CDH prenatally, is there a role for termination of pregnancy? And if so, what are the parameters?
It's not allowed in Poland. It's
Yeah.
not allowed in Poland. And if there is a CDH diagnosed, we have just one center in Poland that is doing fetal surgery and is putting just a balloon into the trachea. But it's not an indication to abortion.
Okay, thank you. We have some of the audience that want to participate. We have Dr. Zafer Ducomo. I'm going to unmute him, please. Yes, hi, Zafer. Welcome to our meeting. Yeah.
It's always great to be with you. You know, I love it. Sherif and Dariusz, that was fantastic presentations. Thank you.
Thank you.
I just wanted to make it clear for the indications for thoracoscopy in CDH. Do you perform thoracoscopy for every patient and check it is available or not, or do you select, to be precise? And one another question, do you have any experience with hepatopulmonary effusions in thoracoscopy?
With what experience? Sorry, didn't understand.
any experience in hepatopulmonary fusions?
No, I don't have such an experience. But if you ask me about indication for endoscopy in CDH, for me it's almost, if you think that you can do a surgery for such a baby, so in my opinion, you can start with endoscopy. If you are not planning any surgery, don't start with endoscopy. So if you are planning to do a surgery, for me, it means that you can start with endoscopy, because in my opinion, it's less harmful than open surgery.
Okay, thank you.
Thank you. Thank you, Professor Dariusz. Thank you, Professor Sherif.
We finished question, Adam?
Yes, we finished questions. There are still one or two persons that are raising their hands.
Maybe Dr. Monser is trying to say something.
Just a moment. May I comment, because I didn't understand the question. If you think about hepatopulmonary fusion, yes, just recently I operated such a case. I just recently operated such a case that the lung was adherent to the liver very strictly, and I had to disconnect it. I had to cut it off. Munter, nice to see you.
Good to see you. I don't know if, can you hear me? I'm unmuted or not?
Yes, yes, you are unmuted. Welcome, Munzer.
Oh, thank you. First of all, thank you very much, Sherif and Derek, for an interesting talk about congenital diaphragmatic hernia. And I just want to take the opportunity to say how sad we are regarding the loss of our colleague Hisham Sakit. But what I want to know from both is, and I think one of the previous speakers or who raised the question as well, do you have any selective criteria to decide whether the actual defect is small or large? And if you decide if it's large, would you prefer doing it openly, or you would carry on doing it thoracoscopically, obviously if you're experienced enough? And what precautions do you take in large defect regarding the patch?
Is
that a fair question, Derek?
Okay.
Yes, yes.
Okay.
Start
Okay.
that.
So if there is any excessive tension in the suture line, so right now with my experience in such a case, I would prefer to do a patch repair. So if I am using a patch, it means that the defect is large. And even if you have just, let's say, 80% of the diaphragm that is defect, the size of the defect, I think that if you have an experience, it's much easier to repair it by endoscopy than by open surgery, you know. But it's my opinion. It's my opinion. So
yeah.
I would like to try. I would like to try to do it, you know, because for me it's not a big problem to make a suturing inside, even if you have a big defect. Because if you have a big defect, if you measure it correctly, you put a mesh inside and just suture the diaphragm with a mesh, and then suture it to the chest. So it's much easier than open such a big defect.
The question whether actually you can predict that before you put the thoracoscope in, depending on the ionotropic support, the intrathoracic stomach, the prematurity of the baby or the weight, and the ventilatory requirements. Would that be an indication that this is a large defect, and then you prepare yourself whether you want to do it thoracoscopically or open to have a patch?
Not such a big experience in such a decision. I think that on the right side, you can imagine that if you have a liver inside, so probably the defect is a rather big, but it's not always a case. On the left side, probably a good indication, a good indicator is a stomach inside the chest, but it's not also always the case, you know. So I don't see it exactly. I don't think that I can predict it.
Excuse me, Adam, may I have a comment, please? Actually, Munzer, regarding the ventilatory setting, if it is high, you expect that you have a severe hypoplasia. And usually severe hypoplasia, I do expect I have a big defect. So I start even by just one look thoracoscopically, but I should have the patch in my hand. And if I do patch, I will do it open, not by endoscopy, because the way I put it, I never can simulate it by endoscopy.
Yeah.
Because I can release the posterior leaf and get to the gyrus fascia and talus fascia all around and interrupted manner, parachuting. And this, I think, cannot be simulated by endoscopy. I know the trick of your question, because this is the point. Cannot mostly. Sometimes I expect it is very big one, and when I go, I find it small, and the reverse.
Yeah.
Yes, but the only degree that if there is severe parameters of lung hypoplasia, I do expect I have a big defect. So I have the patch in my backhand.
Yeah, I mean,
I have a comment and a question for Dr. Munder. Dr. Munder.
Yeah.
Yeah, this is Dr. Khairi with you. Nice to see you. Ramadan Kareem.
Oh, thank you. Ramadan Kareem to you as well.
When you said open, is this mean by default through laparotomy or through thoracotomy? Because sometimes I find even doing open through thoracotomy is better than laparotomy. So what do you think?
Yeah, yes, it's entirely depending on the experience of the surgeon. But my question is logically, can you predict clinically before you put a scope in whether it is a large thing? And I think Sherif mentioned about the ventilation. I think we adopted a scoring system that at Chelsea and Westminster, so we can predict that this is a large defect, and depending on the experience of the surgeon, whether he wants to go open technique or thoracoscopic. But if you go thoracoscopic, which I would advise, is actually making sure that when you do the suturing, and also the actual patch should be floppy with the dome or the doming, as Sherif mentioned earlier on. Which will reduce the recurrence. Apart from that, can I make a comment regarding the malrotation? I don't think there is any malrotation in congenital diaphragmatic hernia. It is a non-rotation. Yes. And you find a lot of the patients, it's only malrotated about, or malrotated of 180. So it's not a pure malrotation, and we shouldn't worry about that at all, unless the patient becomes symptomatic for another reason. So it is a non-rotation rather than malrotation.
Okay, thank you, Professor Munzer. We have Professor Khalid Sherif. He's from Saudi Arabia. He's a professor in the Greek University. He wants to share with us a question or a comment. Professor Khalid, you are unmuted, please. Khalid?
Can you hear me? Yeah.
Yes,
can you hear me, please?
Yes, we hear you clearly. Yes.
Good evening, everybody. It's my pleasure that I joined this very excellent presentations and about the update of congenital diaphragmatic hernia. Thank you, Dr. Patkowski and Dr. Shehata, for this comprehensive presentation. My question, Dr. Patkowski, about the hepatopulmonary fusion. According to the literatures, I don't have experience in such situation, but according to the literatures, I think it's difficult. It's very difficult to separate the liver from the lung. So some consider it as an operable case. Do you agree for that? And if you don't agree, what are the basics to operate such case? How you would divide the liver from the lung tissue? Thank you.
I have just only one case such that I operated recently, and it was really a big challenge to separate the lung from the liver, but it was possible. And if I didn't separate it, I couldn't repair the defect, so it was necessary to do it.
Thank you very much. Thank you. Good luck.
We have a question now. Do you think that there's any role for robotic surgery in CDH?
For newborns, no.
No.
You know, this is my opinion. Of course, maybe Munter, you are experienced with robotic surgery, but for me, you know, robotic surgery is something that is a tool for everybody who is not very experienced in endoscopic surgery. It's because it's much easier to do endoscopic surgery if you are not very experienced with the robotic surgery. But if you have an experience, so probably it's much easier to do it without robotic surgery.
Can I comment?
Yeah.
I don't think there is any role or any place for robotic surgery at this time for newborns.
Yeah.
Any baby who is below 2 kilograms, it's very, very, very difficult to do anything robotically in that patient. So I don't think there is any place for robotic surgery in newborns, or especially in congenital diaphragmatic hernia, unless we actually be able to do micro or mini robots which can do the job for us by introducing it into the chest and ordering it to do the actual suturing or application of the mesh. Otherwise, the Da Vinci, which I use and we use in pediatric surgery, it's not applicable for newborns and not applicable for babies.
Thank you, Professor Monzer. We have one last share from the audience, Dr. Ahmed Al-Adawi. Dr. Ahmed, you are unmuted. Sir?
Yes. I have a question to Dr. Sherif. It is about the group of neonates which are discovered or presented after more than 48 hours of birth, the group with the best survival. Is it also recommended to intubate them and gentle ventilation or not?
Actually, this group is not needed to be ventilated unless they are required. And because they are stand with room air or usual air for 48 hours. And this part was used by Caesar in old Romans. When the old woman in the Roman Empire gave a boy, they only want the strong boys for the army. They left it for 1 day, 24 hours, alone. If he is in the second morning, is alive, they feed him and by breast. So there is no need except there is some parameter, but this is theoretically has no lung hypoplasia and no need for ventilation unless they are required. Okay.
So we don't have any more sharing from the audience. We have a last question. It just comes out to the chat room. Could we take it to be the last question?
Yes.
Okay. The question is. Did you have any cases where you have a complication due to a wandering spleen? And did you need to do any splenopexy to avoid any complications?
I can answer the question.
Yes.
We had one case with wandering spleen after CDH repair, and we had to do a laparoscopy to make such kind of splenopexy because the baby had a recurrent pain in the abdomen. So it was necessary to make the splenopexy.
Okay. There is a question for Professor Dariusz. Have you tried any biological patches, like stresses, for example, in CDH repair?
Never. Never was.
Is there a reason why you didn't try, or because it's not available?
Not available.
Okay. Okay, so this comes to an end with our questions. Are there? We would like Professor Dariusz and Professor Sherif to get the last comments before we end this lecture.
Just one comment I have to emphasize that for all pediatric surgeons, don't be challenging that you have to operate each CDH patient. Unless your patient is not stabilized according to your resources, don't operate the patient, please. Can give Dariusz a last comment.
The last comment. These are very special cases, you know. The surgery is just only a part of the treatment of these babies. So these babies should be referred to the third, tertiary hospitals with a very good intensive care unit with a lot of specialists. So it's really very challenging cases, not only a surgery. So be careful with these cases.
Dr. Ahmed Khairi, you have any last comment?
Yeah, I would like at the end to thank all of you, the audience, for attending, and I'm sure everybody was happy about this comprehensive, talk about this big problem for us as a pediatric surgeon. I would like to thank Professor Sherif, the head of EPSA, for his very informative and comprehensive presentation. Dariusz, you are very happy of having you with us, and really enjoyed your presentation, and we hope we receive you again, inshallah, after this, this pandemic ends and finish. And I hope everybody stays safe at home, and see you in the next meeting of EPSA online sessions. I guess the next talk we'll announce it in the next few days. Is that right, Dr. Adam?
Yes, sir.
Usually every Wednesday.
Yeah, but the topic not yet assigned. Is that right?
No, it's not. We have a schedule, yes, but we're going to announce it
later on.
Probably yes, later on.
Thank you. Okay. Thank you very much for everybody, and we hope we see you in the next meeting. Thank you.
Thank you.